Good afternoon, dear colleagues, and let me introduce our 9 months progress report. My PhD topic is the investigation of techniques and materials in pulp therapy. Some words about myself. My name is Péter Komora. I'm a clinical specialist and a first-year PhD student at the Department of Restorative Dentistry and Endodontics. My vision is the minimal invasive endodontics, and to fulfill my vision, my mission is to reduce the invasiveness in endodontics through evidence-based science. At this moment, we are working on 2 specific goals. Both of them are systematic review and meta-analysis. So our first topic is comparing the efficacy of bioactive materials in pulp therapy. We conducted a systematic review and network meta-analysis. Some words about the background of our topic. First of all, we have to speak a bit about the root canal treatment. It's an invasive treatment option and result in loss of tooth vitality. If we are looking in the literature, we could calculate with a quite good success rate with this type of treatment, but really important to emphasize that failed root canal treatment could end up in tooth loss. The pulp therapy aims to preserve the pulp vitality in order to avoid the root canal treatment. The gold standard bioactive material for these treatments are the MTA, is the mineral trioxide aggregate. But in the last 10-15 years, newer materials came to the market with less drawbacks to MTA. These are easier to handle materials, and these are lower cost alternatives to MTA. So our aim is to compare the bioactive materials in pulp therapy. So we are using the PICO framework. The P is the permanent teeth with pulp therapy. The intervention group are the bioactive materials. The comparator is the MTA, and our outcome is the success rate of the pulp therapy treatment. It means that the patients who were treated, this patient doesn't have any pain, sensitivity after that, or sign of pulpal inflammation, and there are no signs of inflammation on radiographic examination. Our hypothesis is that new bioactive materials are at least efficient in preserving pulp vitality than MTA. We conducted our systematic search in 4 different databases, and we have almost 1,900 results. After the selection, we had 15 eligible full-text articles for the review. So our outcome is the success rate of the pulp therapy treatment, and we investigated the success rate in 6 months follow-up, in 12 months follow-up, and 24 months follow-up. Our measure of effect was the odds ratio with 95% confidence interval. On the first slide, you can see our network plot. Here you can see the investigated materials. This orange circle represents one material, and the size of this orange circle represents the number of patients who were treated with this bioactive material. The lines between the materials represent the direct comparisons, and the number on these lines and the width of the side of the line represent the number of studies. On the next slide, you can see our outcome forest plot and the p-score. On the outcome forest plot, every material is compared to the MTA, and you can see the vertical line, it's the 0 effect, and if the point estimate on the left side, it represents that this material works better in a clinical condition than the MTA, and if the point estimate on the right side, this material performs worse than the MTA. Here you can see that in case of total field, biodentin, and TLC, we don't have mathematical significant result, but in case of calcium hydroxide and light-hearing calcium hydroxide, we have robust mathematical evidence that this material works worse than the MTA in a clinical condition. And the p-score represents the ranking between the materials. It's technically a probability that the material in the proper place of this ranking, and here you can see the MTA is on the first place. The 12 months results, here you can see also the network plot, but more important is the outcome forest plot. Here you can see that the total field in case of biodentin and this calcium-enriched material, there are no mathematical evidence that these materials perform worse than the MTA, but in case of TLC, we have a quite weak mathematical significant result, and in case of calcium hydroxide and calcium hydroxide IC, we have also strong mathematical evidence that the performance of these materials are worse than the MTA. And on the P-score, you can see that the MTA and the biodentin is on the first two place in the ranking. And the 24 months result, you can see also the network plot, and our result here you can see that only in case of biodentin there is no mathematical significant results, and in case of CEM, but really important to emphasize that the CEM was compared just with the MTA, and we have only just one study, and you can see that the confidence interval is really wide, so we have to be cautious with this result. But in case of TRK-IC, calcium hydroxide and calcium hydroxide IC, we have also mathematical significant results, and on the ranking you can see that the MTA is also in the first place, and the second one is the biodentin. So the strength of our study, we included just randomized clinical trials, and we could reach a really high sample size, and we used an integrated method for the success rate calculation, and of course this is a network meta-analysis. But there are some limitations, and not every arm is strong in the network, and there are comparisons with only one study, like in case of CEM. And we concluded that the MTA is the most effective material for vital pulp therapy at 6, 12, and 24 months respectively. However, the biodentin could be a suitable alternative to MTA in a clinical application for vital pulp therapy. And this is our first practical implication that the biodentin could be a good alternative of the MTA. The 6 months follow-up is not enough to evaluate the success of the vital pulp therapy treatment, and after a result, we don't recommend it to use the calcium hydroxide in clinical application for vital pulp therapy. And our implication for the research, the results of the clinical trials need to publish after 6, 12, and 24 months. We need more randomized clinical trials to evaluate the efficacy of the novel calcium silicate sealers, and the demographic data, for example, the age and the tooth type, need to publish also. And let's see the progression of our first project. The core text is ready, and it's already reviewed by 2 supervisors. And on this week, I will finish the supplementary material and the abstract, and our plan is to send it to the internal review in the next week. And our targeted journal is the International Endodontic Journal and the Journal of Endodontics. These are the top 2 endodontic focused paper, and the third one is the dental materials. All 3 papers are D1 journals. And some words about the second project. As comparing the root canal filling quality of calcium silicate-based sealer. This is also a systematic review and a meta-analysis of in vitro studies. So some words about the background. In particular, pulpal and periapical patosis, the only option to save the tooth is the root canal therapy, and an essential step in root canal therapy to maintain a well-sealed root canal system. The AH+, it's an epoxy amine resin type material. It's the gold standard material for sealing of root canal system. But new calcium silicate-based sealers came to the market, and these have some promising biological and clinical benefits. Our aim is to compare the different sealers in root canal filling. We used also the PICO framework. Our clinical question: is there a difference in root canal filling quality of different calcium silicate-based sealer to AH+? Our population is the permanent mature extracted teeth. Intervention group is the calcium silicate-based sealer. The comparator is the AH+ sealer, and the outcome is the quality of the root canal filling. And our hypothesis is the quality of root canal filling with new calcium silicate-based sealer are improved than with AH+. And our clinical and research implication to evaluate the quality of root canal filling with calcium silicate-based sealer. Here is our search key, and we are in the selection process at this moment. So as an overview, you can see our 2 ongoing projects, and you can see our planned submission date. And thank you for your attention.
Congrats for your nice presentations. I have a small questions relating to the first part of your research. How you can explain that the biodentin behavior acting was very similar after 24 months. It was much more better than in the initial stage. What is your opinion? How it happens? Which factors play an important role in it? Because after 24 months, it was similar or near to the same like the MTA, but in the first 6 and 12 months, it was lag behind the MTA norm.
Technically, thank you for your question. Technically, the background is not well known, but could be behind this behavior. Really important to emphasize that we are thinking long-term success. So, and in the long run, it's working quite good. So, in case of MTA, there could be some explanation that the setting process is a bit different. It has a longer setting process, and through the setting process, this material has a really high pH, and it could be an antimicrobial effect, or could be a stronger antimicrobial effect. And the biodentin has a much shorter setting time, and it could be a benefit for us in a clinical perspective, but maybe in the long run, the benefit of the biodentin is coming after the 2 years follow-up.
While they are thinking, I wonder whether the exposure of the pulp was controlled similarly in all these studies before the capping?
Yes, the methodology was similar. It was checked. The status of the pulp was checked with loops or with high magnification or with operating microscope. And of course, there was a disinfection process before the application of this material. So in one study or in every study, it was standardized, but they used a really similar process and similar materials for the disinfections as well in every studies.
Just re-emphasizing from your first study, and that is already asked in a different way, actually. So that means actually, I mean, well, that's not a big surprise that MTA, that biodentin is similar to MTA. So to me, actually, the follow-up, that what to exclude, that's very important. And the other thing, which is very important, is the follow-up, actually, because, many studies do the follow-up only for maximum 1 year or 6 months, and then they exactly are set. So I think this is very important to see that for a kind of valid kind of outcome, you need to do this for longer.
Thank you very much for your comment. Yes, you're right.